Diuretics all increase urine output, but they don't all work in the same place or in the same way. Some act in the proximal tubule, some work in the loop of Henle, and others target the collecting duct. Now here's the key idea. Once you understand where each class works in the nephron, the entire classification suddenly becomes simple. Inside the proximal tubule, carbonic anhydrase normally helps reabsorb bicarbonate along with sodium. Carbonic anhydrase inhibitors like acetazolamide block this enzyme. Now bicarbonate stays in the tubule, sodium and water follow, diuresis occurs, and bicarbonate is lost in urine. That's how carbonic anhydrase inhibitors produce alkaline urine and mild diuresis by blocking bicarbonate reabsorption. Inside the thick ascending limb, the NKCC2 transporter normally reabsorbs sodium, potassium, and chloride, helping create the medullary gradient that allows water conservation. Loop diuretics, like furosemide, block this transporter. Now sodium stays in the tubule, water follows, and powerful diuresis occurs. Blood volume falls, edema decreases, and blood pressure drops. That's why loop diuretics are called high-ceiling diuretics, because they produce profound diuresis by blocking a major renal transport system. Inside the distal convoluted tubule, the NCC transporter normally reabsorbs sodium and chloride from the tubular fluid, moving them back into the blood through surrounding peritubular capillaries. Then, thiazide diuretics, like hydrochlorothiazide, arrive at the tubule, bind to the NCC transporter, and block reabsorption. Now sodium stays in the filtrate instead of returning to blood. Inside the collecting tubule, aldosterone normally increases sodium reabsorption and potassium secretion. Potassium-sparing diuretics, like spironolactone, block aldosterone's effect, while amiloride blocks sodium entry through ENaC. Now less sodium is reabsorbed, water follows sodium, mild diuresis occurs, but potassium is retained. That's why they're called potassium-sparing diuretics. Inside the nephron, water is normally reabsorbed as solutes create osmotic gradients. Osmotic diuretics like mannitol are freely filtered but not reabsorbed, so they stay inside the tubular fluid and increase its osmotic pressure. Now water remains in the tubule, less is reabsorbed, urine output rises, and diuresis occurs.